Hello and welcome everyone. Today we'll be discussing the strategies to minimize lung injury on ventilator. Ventilator induced lung injury or VILI is a recognized adverse effect of mechanical ventilation, causing excessive stress and strain on the lungs, leading to systemic inflammation and potential multi-organ failure in ARDS patients. PCLE is a newly identified condition where spontaneous breathing during the ARDS results in high inspiratory effort, causing large tidal volumes and significant transpulmonary pressure swings, which can lead to hydrostatic pulmonary edema and regional lung overdistension. Now, both VILI and PCLE significantly contribute to the worsening of ARDS in a substantial number of patients. Now, preventing this is emphasized to improve outcomes in ARDS, and bedside personalized treatment based on patients' monitoring, adapting to the individual's physiological phenotype is essential. Most recommended strategy to mitigate VILI and PCLE can be executed without any additional equipment, making them viable in the settings of limited resources. Now, high flow nasal oxygen, CPAP, and NIV each have a unique physiological impact, influencing outcomes in acute hypoxemic respiratory failure. HFNO is shown to reduce the risk of intubation in acute hypoxemic respiratory failure patients. Similarly, CPAP and NIV are widely used globally. These are not formally recommended but may be considered in certain cases. Now, awake proning is again something which has been done during the COVID times. Prolonged sessions may enhance lung protection under very specific clinical conditions. But all these things, they have a problem in themselves. That is the risk of delayed intubation, which is associated with even poorer outcomes. So potentially due to the development of PCLE during the treatment. Now, impact of non-invasive support on respiratory system. Prolonged exposure to hypoxemia and high respiratory rates during support leads to reduced compliance and challenges maintaining the safe driving pressure post-intubation. Now, monitoring the support of failure is very essential. So, it is important to monitor the patients for early signs of non-invasive ventilation failure using tools like the ROX index and the HACR score. Now, what are the predictors of failure on NIV or non-invasive ventilation? For the HFNO, what we use is something called the ROX index, which is saturation by FiO2 against the respiratory rate. HACR score assesses the heart rate, acidosis, consciousness, oxygenation, and respiratory rate. Lack of inspiratory effort reduction, which is measured by esophageal pressure, but then it may not be always feasible, but can be visualized also in helmet, can also be a sign of non-invasive ventilation failure. So signs that indicate the need for intubation are worsening clinical signs like PF ratios, increase in the respiratory rate, escalating dyspnea, which may indicate the necessity to intubate. So to summarize how to reduce the PCLE in ARDS patients who are being managed with these devices, for HFNO, what we use is this ROX index, which is saturation by FiO2 multiplied by the respiratory rate, and the HACR score for the face mask or helmet. So this is the index that you monitor. Apart from that, you also strictly monitor the saturation FiO2 or the PF ratio, respiratory rate, and the dyspnea in the patient. If the ROX index is going less than 3.5 after 12 hours of HFNO, then it is the need to intubate the patient because we are not seeing any signs of improvement. You can also check the delta ROX, because if that is also not changing, then it is better to intubate the patient rather than continuing endlessly like that. The other thing is the use of CPAP. In CPAP also you can use the ROX index. Here, if this after 24 hours of giving CPAP, if my ROX index is less than 5 or 6 and there is no delta change improvement in the ROX index, then I can go for invasive ventilation. Similarly, for helmet, as we have already discussed, a lack of an inspiratory effort can also be taken as a trigger to worsening an intubation. For face mask and IV, the thing that you need to note is high tidal volumes. Any tidal volume of more than 9.5 ml per kg predicted body weight is a sign that the patient is continues to be dyspneic, and there is going to be severe swings in the transpulmonary pressure because of these large tidal volumes. Apart from that, the Hackar score of more than 5 after 1 hour is also an indicator of intubation. So starting the patients on these devices is not a contraindication, but once you start these devices, especially in ARDS setup, please monitor the patient both clinically as well as with these indices, and do not delay the intubation, because delaying the intubation or seeing no signs of improvement with these devices doesn't really guarantee continuing these devices. Immediately, if we are finding no improvement, it is better to go for intubation, because PCL is going to worsen my outcomes. So coming to the invasive ventilation. So in invasive ventilation doesn't really mean that we are not causing any lung injury. In that also we need to reduce what is called as the ventilator induced lung injury. So tidal volume and driving pressure are crucial in managing this VILI. Delta P, that is the driving pressure, indicates the lung stress, and it is calculated by the ratio of tidal volume to the respiratory system compliance. High elastance suggests a benefit of reducing the tidal volume, aiming for less than 6 for predicted body weight. Low elastance permits large tidal volumes, reducing sedation needs and easing the transition to assisted ventilation. We need to optimize our ventilator settings. Start with 6, then adjust the tidal volume to maintain a delta P of under 15. Awareness that PEEP set below the airway opening pressure might overestimate the driving pressure. Ongoing clinical trials are investigating the benefit of titrating the tidal volume to limit the driving pressure. So, regarding volume versus controlled pressure ventilation, no significant difference in outcomes have been observed. Airway pressure release ventilation with time controlled adaptive ventilation could offer more protection against VILI. Now, balancing the tidal volume reduction and the respiratory rate. Excessive reduction in the tidal volume may be balanced with changes in the respiratory rate to maintain an adequate alveolar ventilation. High RR can as such be harmful. Optimal setting, minimizing the sum of 4 into the driving pressure plus RR to reduce the mortality risk. Mechanical power, which accounts for the effects of respiratory rate, PEEP and airway pressure on tidal volume in VILI, is useful but challenging to calculate at the bedside. Prone positioning. Now, proning for 12 to 16 hours is effective in reducing VILI, reverses the right ventricular failure in moderate to severe ARDS. Consistently improving oxygen should be maintained regardless of the intermediate oxygen improvement to prevent the VILI. PEEP and lung recruitment is also important. High PEEP is effectively prevents VILI when it expands the aerated lung sufficient to reduce the dynamic strain. Effectiveness of PEEP depends on the lung's recruitability. Poor recruitability can lead to overinflation of the baby lung and contribute to the VILI as well. Assessing recruitability at the bedside is very important. Recruitment to the inflation ratio, that is the RI ratio, which is measured using a single breath PEEP reduction maneuver. RI values below 0.5 to 0.3 indicate poor recruitability and suggest benefit from lower PEEP settings. Higher values warrant higher PEEP. Hysteresis ratio gauges recruitability by comparing maximum distance between the inspiratory and the expiratory limb in the pressure volume cycles. Observing compliance changes during decremental PEEP trials can predict lung recruitment but are less informative when used alone. Finally, the transpulmonary pressure in VILI management. Transpulmonary pressure is a critical measure of lung stress and a key determinant of the development of the VILI. Now, absolute esophageal pressure readings reflect the pleural pressure in the lungs mid to the dependent zone, influencing the lungs collapse. Calculating the end expiratory transpulmonary pressure is important. It is determined by subtracting the end expiratory esophageal pressure from the PEEP during a expiratory pause. Setting the PEEP to achieve a end expiratory transpulmonary pressure close to 0 prevents atelectroma and may improve survivals. Now, estimating the end inspiratory lung stress. Direct measurement can be derived from the formula, that is this, which is elastance derived method, where the PLEI is estimated from the plateau pressure, that is P plat, multiplied by the ratio of the lungs elastance to the respiratory system. This method accounts for the inability of the esophageal pressure to accurately measure the pleural pressure in the non-dependent parts of the lungs. So what is the clinical implication? A high ratio, that is a P-plat between 28 to 30, may seem safe but should be lowered to reduce stress on vulnerable lung regions. What does a low ratio indicate? In recruitable patient, increasing the PEEP and tolerating a PEEP plat above 30 can be beneficial for enhancing the oxygenation. Safe limits for the inspiratory plateau pressure is suggested to be between 20 to 23 to minimize the risk of overdistension and subsequent injury. How to transition to assisted ventilation? Assisted mode of ventilation should be initiated as soon as feasible to manage the ARDS effectively, monitoring inspiratory effort to prevent PCL. Inspiratory effort during assisted ventilation should be closely monitored to avoid exceeding 10 to 15 centimeters of water to minimize the risk of patient self-inflicted lung injury. Now, use esophageal manometry for accurate measurement. Alternatively, assessing 75% of the airway pressure deflection during an expiratory hold can estimate the inspiratory effort. To look at more details regarding these calculations, you can look into our previous video. Now, how do you manage the driving pressure and PEEP in assisted ventilation? The driving pressure should be maintained within safe limits as previously established, and increasing PEEP can reduce the inspiratory effort if it improves the respiratory system compliance. Assessing the respiratory drive with airway occlusion pressure, that is P0.1. P0.1 is the measure of respiratory drive. A value greater than 3.5 to 4 indicates potential harmful inspiratory effort. High respiratory drive and excessive inspiratory effort can cause asynchronies like breath stacking, increasing the risk of lung injury. So, how to optimize the pressure support and sedation? Proper adjustment of the pressure support and sedation can help regulate inspiratory effort and respiratory drive. Propofol and opioids are commonly used to decrease this, respectively. Additional techniques are phrenic nerve stimulation can aid in transition to assisted ventilation to reduce the risk of BILI, improving lung mechanics. Utilizing the prone positioning during spontaneous breathing has been shown to reduce effort of the dependent lung injury. So to summarize everything, the two things that we need to control are the driving pressure and the tidal volume. So tidal volume, you keep somewhere between 4 to 8 and keep the driving pressure less than 15. Heated humidifiers facilitate tidal volume reduction in isocapnic conditions. Prone positioning is already being done. A 12 to 18 hour session in patients who have a PF ratio of 150 is beneficial. PEEP and recruitment is also very crucial. High PEEP should be limited to patients who have high recruitability. Techniques to assess this recruitability is important. Multiple pressure volume curves, that is low pressure inflation, low flow inflation at different PEEP levels, recruitment to inflation ratio, electrical impedance tomography setting the PEEP to achieve an expiratory pulmonary pressure of 0 may be sound, especially in patients who have high recruitability profile, and elastance derived end inspiratory transpulmonary pressure of 23 as the upper limit of ventilation may also allow safe increase of PEEP if the plateau pressure is more than 28 to 30. So these are the various methods that we are using, that is calculating the power and reducing our respiratory rate and tidal volume accordingly, using the PV curve to look at the recruitment inflation ratio, the transpulmonary pressures, the use of electrical impedance tomography. So now, how to use the safe assisted ventilation? Patients with a PF ratio of less than 150 are at risk of PCL. Just because the patient is on ventilator doesn't mean that the patient won't develop PCL. If the patient continues to breathe bad on ventilator in assisted mode, then patient will develop PCL. Now here, try to keep the tidal volume not more than 10. High respiratory drive if the P0.1 is more than 4. Occlusion pressures to calculate the indices that we have already discussed before also. Keeping the delta P more than 14 and a P plat of more than 28 to 30. These are the various maneuvers that you need to do to calculate the pre-oc and the pre 0.1.